some of the important differences between FEP services and CHRP services. And we'll talk there specifically about how you costs out these studies, what unit costs look like, and sort of the technology that you need to be able to bill both Medicaid on a team-based basis and or commercial insurance. Let me okay the recording. And then part two, we'll dive into CHRP and how it's currently being funded. Talk about sort of the core components, and then and Brenda's going to make some important distinctions, I think, between sort of what we might call the philosophy or the approach to care versus things that are actually billable, which has implications for training as well as for reimbursement. So bear with us as we talk a little bit about FEP, and then we'll dive into CHRP for a substantial period of time. Next slide, please. So in honor of offering CEUs, we have learning objectives. And so those will be described in multiple strategies to finance CRP services in the future, depending upon the program structures. That resonates back to this idea that there's a difference between CSC and CHRP programs. Describe current strategies for funding clinical high risk and outline next steps to obtain sustainable funding for clinical high risk programs. Next slide, please. So part one, first episode, Psychosis, a primer and blueprint. Next slide. My guess is most everyone on the call is familiar with coordinated specialty care for first episode psychosis, but it's a wraparound type service, and it includes psychotherapy, medication management, family education support, service coordination and case management, support employment and education, and increasingly includes peer support. So the challenge in financing this was to develop a financing mechanism that really responded to the structure and philosophy of the program. When we applied for the billing codes with the CMS, Brenda characterized this as really a new technology that has to be funded as sort of I don't want to say bundle because that's not what we want to do, but it has to be funded at a team-based level and has to cover all the services that are required to actually implement a CSC program. And we were successful in convincing CMS. And in part, that's because of the next slide. Learning from the current approaches for funding it. So I think as everybody knows, excuse me, the block grant set aside made a huge difference in terms of the growth of these programs around the country. And that's an interesting story about the set aside too, since it came from a tragedy, the shootings in Connecticut and the Congress and the president's wanting to do something in response to those horrible shootings. And NIMH and CMHS were proactive in terms of meeting with congressional staff and suggesting that the RAISE results and the STEP results, international results, really talked about the fact that these programs could really help to get to people more quickly and help them. And that resulted in a 5% set aside, which was doubled in the next year to 10% and has made an enormous difference. I think, as you know, you typically use a mixture of block grant funds, state general funds, and insurance payments. And even with the states that have expansive Medicaid benefits, and I'm thinking specifically of New York, only half of program costs can be covered utilizing outpatient fee schedules and fee-for-service billing. Team-based reimbursement, so that's this notion of covering the entire technology, was critically important. And there's a risk, and Toshida will be able to speak directly to this in her presentation. There's a risk of reliance on the discretionary resources like the block grant, and it's not an entitlement, and or the CHRP demonstration grants that they don't support long-term sustainability. And so without establishing an insurance benefit, that program will never meet the population in need. And again, that's the rationale that we use in order to expand it. We need to use like the block grant funding, state funding, and other funding for certain activities and for startup. And But we need an insurance payment mechanism if this is going to be sustainable. And finally, the lack of a specific billing code we discovered was an implement for the implementation of the Illinois mandate to cover first episode psychosis among other services. And so that set us on this quest to get a HCPCS code. Now, part of our argument, next slide, please. Part of the argument related to what were known to be the benefits and outcomes associated with coordinated specialty care. I'm sorry, I skipped ahead in my psychology here. So, non-service components. So this is this notion, and Brenda will talk about this later. This notion that in addition to the specific services, there are other aspects of this technology which require a team-based rate, like frequent team meetings, frequent collateral contacts, small caseloads, unlicensed team members. All of these are concerns for sort of traditional billing processes, and make it difficult to run a CSC program to cover the costs of that program exclusively using ordinary outpatient-based fee-for-service reimbursement. Next slide, please. There we go. That's what I thought the next slide was going to be. So part of what we were able to do, and I think there's a question mark here with regard to CHRp programs, what we were able to do was to show the outcomes that were associated with these programs, both in the United States and internationally. And Bob Heinsohn, who was the champion of this from an IMH, had great confidence given the results of the international trials that we would see reduced symptoms and increased quality of life and reduced service utilization in terms of inpatient and emergency services. Next slide, please. And here we also were able to, and this is available in a SAMHSA publication, to document the fact that in the vast majority of studies that looked at cost offsets associated with coordinated specialty care, there was positive results in the vast majority of them, indicating a decreased cost level for inpatient and emergency services that offset the cost of coordinated specialty care. I'm getting a notion that my internet connection is unstable, which is never good to do when you're doing a national presentation. So hopefully I won't freeze up on you, and we'll take a look at the next slide. And I think, Brenda, if I remember correctly, you're going to take over at this point in time in terms of the CSC story.
Yes. So where we ended up going is having a team-based HCPCS code. That team-based rate and that code are all based upon the predefined set of services for the evidence-based practice of CSC, usually a Navigate or a OnTrack or an ESA. There are also some Addington scale fidelity models. Ohio has a fidelity model, and it emphasizes the need for a team-based rate. The reason that we do that is an office-based fee schedule typically incorporates the wages for the licensed practitioners who provide psychotherapy in an office-based setting, but it really doesn't take into account those non-service components that David just talked about, like small caseloads, team staffing, team meetings, unlicensed practitioners, and the extraordinary training and supervision and certification costs, fidelity costs, as well as the lost productivity due to collateral contacts, travel associated with community-based services, daily team meetings, outreach, telephone calls, or extraordinary documentation. So we started using the the concept that the assertive community treatment teams had started with, which was a team-based rate, and we were able to then get caseloads and a rate, a model established that CMS has been accepting. If you go to the next slide, where we ended up having is looking at the caseload expectations based upon the number of individuals that would be served, the vacancy rate on that team, but looking at the totality of the staffing costs for the prescribers, the team leaders, the licensed therapists, including the family educators, the peer specialists, the skill building specialists, the family education, and the case manager. Now notice all of these individuals are providing direct services to the clients. And so when we think about how we set up first episode psychosis CSC teams, we really were thinking about what is the insurance service that is being delivered. And we also had to look at what were the percentage of the individuals who were requiring those skill building services, either in an educational setting or in a work site, or who were receiving the community-based services. Because one of the things that did matter was the terminology being used. Language was very important. The way that SAMHSA oftentimes structures their NOFOs or talks about something, they might be talking about a process. They might be talking about a philosophy. They might be talking about how they see the service, but it really matters how the insurance covering the service thinks about it. So for example, we thought about training not in terms of the entire totality of the workforce. We talked about training as it related to the people on the team providing the services that were covered in the team-based rate. So rather than thinking about community training, we thought about staff training for the staff who are providing the services within that rate. We talked about what are the certification of fidelity for that team, not for the totality of the system that we were trying to change. We weren't talking about planning the system. We were talking about this particular team that provides these particular services. So when we talk about staff travel, we were talking about for the team that's outlined, the prescriber, the team leader, the licensed therapist, what is their travel that is related to the service that they are providing in the community, not traveling to a conference, not traveling in the big picture. We also looked at what the staff turnover was for that team, or the interpreter for that caseload, or the overhead for that team. So a lot of times when we are talking, language matters, semantics matters, and how we set this up matter. And we're talking about this in terms of FEP and CSC, because when we start talking about CHRp in the next section, we're going to talk about, well, wait a second, how is this being characterized? How is this being set up? And how do we have to talk about this from a financial sustainability perspective so that we can get it covered in a long term outside of a grant funding situation? So if you go to the next slide, we also have to think about what are the various provider billing rules and strategies. And so when we were talking to CMS about the codes and how it would be set up, we started talking about a monthly case rate or an encounter rate. And we started talking about how the utilization of services was dependent upon the needs of the service and the participant. Oftentimes it's higher at the onset, lower later. And we started talking about how for a case rate, the provider is paid regardless of utilization, but there has to be at least some utilization. This is not what we would think of as an insurance rate, where regardless of whether they see someone, they get paid. But we look at what's the average utilization and how would we make sure that at least some utilization is taken into account, or what's the minimum utilization that needs to be provided in order to draw down that account, that case rate. So when we worked with CMS, they gave us two case rates. One is a monthly case rate that is billed when there is any encounter by the team member where there's at least a minimum number of encounters. And so maybe 4 or 6 times a month, so long as the team has provided 4 or 6 meetings with the client, then we would allow the monthly case rate to be paid. If you're not having 4 to 6 case rate meetings a month with the client, then we look at more of an encounter based, where let's say you only have 2 encounters that month, you would then be paid on a per encounter basis, which is that H2041. Now, the thing I want to make sure you all hear is you don't have to go back and necessarily get a new code for CHRp. You could do something like use the existing H2040 and the existing H2041 components if you have clinical components included in your CHRp programs, and use a modifier like an HK modifier, which is specialized mental health programs for high-risk populations. However, as we're going to talk about in the next section, it matters how you pay for and how you structure and refer to those clinical components. And we're going to talk through that. If you go to the next slide, the way that FEP uses the 2 rates is for the first 24 months, they would say if you provide at least, in this case, 6 encounters per month, we're always going to pay you in this case, it's a small team. They only see like 15 or 20 people. We're going to pay $2,900 per member per month. If you do at least 6 encounters for each person on your caseload, you will get that for every person on your caseload. However, if you only provide 1 to 5 encounters per month, then we're going to pay you an encounter rate of, say, $493. Now, after the 24 months are over, then you're going to step down potentially, and we're going to only pay the encounter each time you see the team, and that would be that $493. Now, that's a small team example. Let's go to the large team example, where maybe you're seeing, that's on the next slide, where maybe you're seeing 25 to 50 people. And if you see a person from the team maybe 6 to 10 times a month or more, you'll be getting the $1,900 per person. Or if you are not seeing them at least 6 times, you would get the $319 per person every time you see them. And then for the after the 24 months, then you just get that encounter rate. Now, I see there was a question that just came up in the chat. How are these codes entered for billing if not attached to a specific patient encounter? So for the per member per month, the way that is done is the provider would bill the H2040 once a month, once they have had at least 1 encounter or at least 6 encounters that month. Now, if you don't ever get to 6 encounters that month, then at the end of the month, you would go back and you would say, oh, we're only going to bill the H2041 for the 5 encounters that we had that month. And so that's how it's billed. Now, you can also do this where you only use the H2041, and you can do that up to 6 encounters. And so basically what you would be doing is saying, instead of billing the per member per month of $1,914, we're going to allow you to bill up to 6 encounters a month of $319, which 319 times 6 happens to be $1,900. Okay, if you go to the next slide, I am going to turn this over to Tushita.
Thank you, Brenda. Thank you, David. My name is Tashita. I am been helping Steve and Judith in this Summer of Learning series, Learning Health Community. I am so glad to see everyone. The timing of this could not have been better. I know the new grant announcements came out, and so it is exciting to see what everyone is kind of thinking about their programs in terms of next steps. I will not talk about what is CHRP. The reason why you're here is because you're providing CHRP services. I am here to point out some pertinent differences between how CHRP processes and philosophy is different from CSC or FAP process or components. Next slide, please. One of the major differences that the SAMHSA NOFO has, for CHRP NOFO, SAMHSA used the word SAMHSA required activities. For those of you who have co-located or combined programs, SAMHSA requires core components for a CSC programs, which is not a requirement, which is not in the language in NOFO. So SAMHSA required activities as train mental health providers, develop outreach educational activities, screening assessment, kind of have referral pathways, service coordinations, implement a step care model, and promote and sustain youth family participation and have individualized crisis plan. What stands out to me as someone who's been doing this work for the last 7-8 years is a lot of these required activities are processes or philosophy, as David and Brenda pointed out, and not necessarily clinical services. For example, promote and sustain youth and family participation. It's kind of like a broader overarching philosophy or process that the program does, or trains their workforce in versus a direct clinical service. Similarly, with something like develop outreach and educational activities and train mental health providers, this kind of points out to a broader grassroots community-based approach that is much more kind of embedded in the preventative policy, preventative kind of thought process that SAMHSA has when it kind of comes to CMHS providing this funding. Next slide, please. Judith, next slide, please.
Okay.
All right. Oh, did we skip?
Go back. Yeah, go back one.
Sorry, I think we might have skipped
Yeah,
one.
I made the same
Oh, there we
mistake.
go.
Was
Thank
looking.
you.
There we go. Yeah.
Sorry, thank you. So SAMHSA requires presence of these or availability of these interventions as part of step care model. So again, just kind of pointing out pertinent differences between a CSC for FAP, which requires kind of like a wraparound model, which is a wraparound model with all the services kind of built around a young person, versus a step care intervention where you go up and down based on the severity of needs of this young person. So you might start at a lowest level, which could be, psychoeducation and just ongoing assessment of CHRP symptoms and go up in terms of the services you provide, or the other way around too. So not everyone needs or receives all the services at the same time. This is kind of like a broad process or philosophy difference between CSC and clinical high-risk stepped care intervention. Next slide, please. And SAMHSA has highlighted these 4 key personnel, which who need to be part of the project. But program director, coordinator, outreach coordinator, and clinical service provider. So outreach coordinator and the outreach coordinator is a unique position that CSC does not require. So this is kind of unique because of the emphasis on broader community-based preventative work and got a lot of psychoeducation outreach in the community. And the definition of clinical service provider is also pretty broad in terms of who counts as a clinical service provider. Next slide, please. All right, Brenda, I think it's back to you. Thank you.
David, do you have anything to add on the key personnel before we go?
My only thought about that, because that'll be very familiar to the people on the call, is that when Brenda and I started to learn more about CHRP and preparing for this presentation, seeing that the key personnel were structured in the way they're structured, so immediately suggested that the program model was different than coordinated specialty care. And Brenda's going to go into that in some detail, talking about sustainable financing for CHRp programs. Brenda?
Yeah. Thank you, David. And as we're looking at the overall revenues of the CHRp program, we're looking at the CMHS discretionary grants, the block grant set-asides under certain circumstances, state funds, Medicaid funds, private insurance. We just want to make sure that you all hear that there are certain aspects of those NOFOs that Tashita just went through that block grant or state funds are going to have to pay for. Medicaid and private insurance is never going to pay for outreach or counseling for the benefit of the family members or community stakeholder meetings, program development, youth and family councils, mentoring, and other activities that are designed to promote or sustain youth and family participation. It isn't because it's not valued, it is because it's literally not permissible to cover those under Medicaid. The other thing that, as we've talked about, is that outpatient fee schedules don't include indirect costs of training staff that are not associated with the providers literally providing the service. They also don't pay for community-based care in general as a concept. They provide staff travel for the providers that are providing the service for their beneficiaries. And they don't provide reimbursement for team meetings as a standalone activity. They provide reimbursement for lost productivity due to items for the staff who are otherwise providing services if they're spending time on documentation and travel and team meetings. And so how you set the semantics up and the language up really matters. The other thing that really matters is that grants and Medicaid cannot pay for the same components of a service for the same individual. So if a grant is received, you need to clearly delineate what the grant is reimbursing versus what the other funding sources are going to be covering. So for example, if you go back one slide, Judith, that outreach coordinator, I can just tell you right now, if you ever have outreach coordinator in documentation, that's an automatic, Medicaid's not going to pay for it. If you have program coordinator, they're going to go, what's the role of that program coordinator? What are they doing? And how is that related to our covered beneficiary? And so as we talk through this, they're going to say, well, I can see how the clinical service coordinator is literally providing services to my client. But if you're getting grant funding for those top 3 key personnel, I'm not going to pay for them again. So if you go forward 2 slides now, Judith, Medicaid is going to generally pay for Medicaid clinical services delivered to Medicaid eligible members. And I'm emphasizing Medicaid because if you can get Medicaid to pay for it, that's your low-hanging fruit, because then you can probably start convincing private insurers to pay for it, or the private insurers with the Medicaid book of business will start paying for it. So just keep in mind, we start thinking about, what is my strategy for getting CHRp funded? Medicaid will set its reimbursement up based upon the salaries and fringe benefits for delivering the Medicaid services. And so when I went through the NOFO, that would be the assessments, psychoeducation, assessments for substance use, cognitive behavior therapy, other behavioral health interventions, rehabilitative supports in an educational or workplace setting, including collateral supports This will be like skill building. Peer and family support with lived experience, psychiatric consultation on the use of pharmacotherapy, service coordination with other Medicaid providers, and the development of crisis plans. Literally from your NOFO, that's what Medicaid's going to pay for. Now, if you say supported education and employment, Medicaid's going to go, yeah, we're not going to pay for that under our state plan. But if you say, well, no, we're talking about skill building that happens to be at an educational or workplace setting, they'll say, oh, yeah, we can pay for that. Language matters. Medicaid will also pay for the portion of those requirements of those services I've just listed associated with the Medicaid clients, training the practitioners providing those services, lost productivity of those practitioners associated with team meetings, documentation, training, travel to provide services in the community, or other uses of Medicaid administrative match. There are also, keep in mind that private insurance typically reimburses for just clinical services as well. Now, if you keep on, okay, we're going to talk about that, Lauren. Let's stay here just a second. What is going to be built in is you don't bill Medicaid for training and team meetings. You bill Medicaid for the services, and the rates will have the costs of lost productivity due to team meetings and costs of training for those staff built into them. There is never going to be a Medicaid line item that says team meeting. It will always be like CHRP per encounter. That's why that encounter rate was $319 rather than $100. So as you go on to the next slide, we also have to think about braided funding. The block grants and the grants, Medicaid, commercial insurance, and state funds all come together to fund CSC. You will have to figure out ways that they will all come together and fund CHRp. And so we will braid the funding so that you have access to an array of services that might not be able to be provided by one source alone. So Medicaid will pay for Medicaid services and the training of Medicaid providers, but they won't pay for non-Medicaid individuals. Same with insurance. And so you really need to think about how all of these things work together with state and local and mental health block grants. The challenge is that the funding sources have different rules, and you do have to follow the different rules, and you have to have fund accountability from the insurer all the way down to how the money's used. That does increase burden on the provider, but I will tell you, having lived through efforts to try to have what's called blended funding, it has been universally rejected under the current statutes and the current insurance models. And so what we're trying to do is save you all some time to not try and go get blended funding, that braided funding is the way to go. So if you go to the next slide, when we talk about Medicaid funding, we're going to tell you how you get different authorities. And this is a conversation in and of itself. And so somebody was saying what states are currently using these codes today. So for example, there are some Medicaid programs that use the Medicaid first episode psychosis codes or something similar to that under what we call a Medicaid state plan authority. That would be New York and Washington. There are some that use an authority called in lieu of services, and this would be Pennsylvania and Texas. There are others who are covering this service under their Certified Community Behavioral Health Clinics, CCBHCs, And if your state has CCBHCs like Missouri or Kansas or Colorado, this is a great way to move forward because it's actually easier to get these services to put into a CCBHC than it is other ways. The thing to keep in mind, though, and this is the fourth bullet and it's bolded, if CHRP is not providing clinical services, you are only referring to clinical services, you may have to look at a completely different kind of authority and reimbursement structure, like a targeted case management, where all you're doing is paying for the service coordination. Because if all you're doing is service coordination, and you're not actually assessing and providing cognitive behavior therapy, and you're not providing peer support, and you're referring to providers who do that, then the per member per month in the encounter perspective that we're looking at for FEP-CSC is not going to work for you all. And so what you've included in your CHRP staffing really makes a difference. You also might look at a severe emotional disturbance child's waiver for providing some of that wraparound if you're not actually providing the assessment, the CBT, etc., by your team, and all you're doing is referring. So the other thing is, keep in mind that supported education and employment can only be provided under a waiver, but skill building in an adult educational setting is coverable by Medicaid under the state plan, and that's a rehabilitative service. And so you really need to think about, are you doing rehabilitative skill building, or are you doing habilitation, where the person has never had a skill and you're building it from scratch? Keep in mind also, and I'm trying to coach you all through some language issues, team-based rates are based upon the cost of the salary, the cost of the training for that individual, that staff person, the staff travel, the certification of that team. They are not bundled, blended rates, which are taking medication management and therapy and peer support and adding it up and saying, well, if I provide a medication management and a therapy and a peer support, that's worth $150 and another $100. So I should get $250. That is what we call a bundled rate. And so keeping in mind that how you do this really matters, and the devil is in the detail. I'm giving you a taste of this. If you need more guidance on this, David and I are happy to sit down and talk to you all about it. So if you go to the next slide, we want to show you then how you might approach CHRP financing. What we've done is we've taken Tashida's first example, and you'll see in the left-hand column, these are the NOFO examples of, and we're going to show you where process, philosophy, and infrastructure building comes in under the grant versus service delivery by clinicians and the actual service and insurance funds. So, for example, training all mental health providers about how to refer to CHRP would be something we would see the project director doing under the grant for the startup of new providers. On an ongoing basis, it would be built into the service costs for the team that's actually providing the services to the CHRP enrollees. But it would be services like the assessment, the clinician providing the assessment, the peer providing the peer support. The development of outreach and educational activities, we would see that as a role of the outreach coordinator, and that would be covered under the grant. For screenings and assessment, we would see the setup and the development of that entire thing as an activity the project director would do. and they would use grant funds to do that infrastructure development. But the actual screening and assessment for an individual youth would be service funding by maybe the Medicaid or the private insurance once all of that is set up, with the clinician not being paid for by the grant. Now, if the clinician's being paid for by the grant, then Medicaid just wouldn't participate, or the insurance wouldn't participate. So for a referral pathway and service coordination, if you're setting that up, and we would see maybe that being the program coordinator setting that all up, making sure that there's relationships and that you know who to refer to when. We would see that as a grant fund or an infrastructure development piece. But if it's an actual LCSW picking up the phone and calling an LCSW in the community or a psychiatrist in the community, then we would see that as service funding that would be actually paying for those calls, or to the primary care provider. Implementing the stepped care model, that infrastructure development would be the project director. They might be doing community workshops, community planning, etc. But Medicaid and the insurance wouldn't necessarily pay for that big planning. But when you actually are having the doctor's visit, the peer support model, those clinicians, whether they be licensed or not, that would be paid for by the insurer. Then promoting and sustaining youth and family participation, that is more of a process. We would see the project director making sure that that process is implemented. That would be grant funded. And then the development of individualized crisis plans, we would see that setting that concept up, doing the training on that would be a project director issue funded by infrastructure. But when it's actually done for an individual person, it would be funded by the services funding, Medicaid or the private insurance. So if you go to the next slide, I'm going to layer one more approach on this. So this is based upon Tashida's second slide. And thank you, Jessica. We're doing a call out to you. This is something Jessica developed. We appreciate you. So when you think about the stages of early episode psychosis or clinical high risk, you need to think about, is it a process? Is it a service? So shared decision-making is extremely important, but that's a process led by the project director, which would be funded by the grant. But an assessment for symptoms would be a clinician-led, maybe LCSW or psychiatrist, and we would see that getting service funding. Now, in your startup, maybe you don't have, maybe everything is getting paid for by the grant. But in the long run, for sustainability, we now want to make sure that you're starting to bill insurance for those assessments. Monitoring for emerging comorbid disorders, that would be a clinician activity paid for out of the service funding. Peer and family support, we'd see that as a peer support paid for out of service funding. Individual or family psychoeducation, substance use, and cognitive behavior therapy, those are all clinical activities, clinical services. The insurers would be paying for that. Now, education on crisis service and crisis planning, we would see that as an outreach coordinator activity, and it would be grant funded. Coordination with the crisis teams, we're envisioning that being the LCSW picking up the phone and calling the crisis team, or the crisis team calling the LCSW on the team or the LMFT and saying, hey, so-and-so came in last night. We're referring them over to you. We need to make sure we're all on board. We would see that as being service funded. Occupational therapy would be done by the occupational therapist, and that would be service funding. Psychiatric consultation would be the prescriber, which would be service funding. Now, for the referral to FEP services, we are thinking that that's going to be a program coordinator activity, grant funded. We could be wrong there. And then for the follow-up services, it really depends on the service. Are you talking about a process? Are you talking about a service? Are you talking about community engagement? What do you mean by follow-up services? It really depends on who is a staff person. Is a grant picking up the salary of that grant person, or is it a process led by the project director or the program director, community engagement led by that outreach coordinator, etc. So I am going to pause right there. Jessica, is there anything that you want to say before or questions that you want to ask, since we've picked on you today and we appreciate you?
No, I really appreciate this. I think it's a good reminder that this is all a team effort and we need to learn from each other and yeah, learn from other people's mistakes. And like I said, Ming Wang, my previous supervisor, created the original kind of version of this when we first applied for CHRP in 2018. And it's been a nice tool. And, there's that note at the bottom about like, all of these things can happen at any time. But I appreciate you laying out the funding pieces and being able to talk about that, because I think for us here in Utah, figuring out more sustainable funding for CHRP is really critical. We're lucky enough to be kind of in the next step of moving toward the team-based rate for FEP, but sustainability for CHRP is the next frontier for us. So thank you for laying it out this way.
Sure. Okay, with that, if we go to the next slide, I am going to turn this over to, is it Heather?
To me, to
Okay,
Purva.
Thank you.
Awesome. Thank you so much, Brenda, for breaking this down. I think it really helps us. It gives us a lot to think about, especially those of us who are building programs or trying to figure out sustainability. And so with that, we're going to move into our breakout group activity. And so this is going to be 10